Good afternoon, everyone. My name is Scott Polanski. I'm the healthcare payer practice lead for Appian. I've been here about a year now, and my role is to help support the sales efforts around the country and help develop some thought leadership and provide help with our collateral development as well. And I know a number of you in the audience and had the pleasure to work with you over the past year. Excuse me. So we're going to spend about 35 minutes talking about the patient of one, how we're going to increase member and patient engagement. And it's my pleasure to welcome our speaker, Jeff Rivkin, who's with IDC. He's an analyst with IDC. And you can see his bio up here. And hold this. And you can see over there, as I was looking at Jeff's resume and bio, and after having talked to him, I can absolutely say that he is certifiable, as you can see with all the designations over there. So I think you're going to hear a great session from Jeff. We're going to leave about 10 minutes at the end for questions and answers. And at this point, I'll turn it over to Jeff, who's going to walk us through things.
Thanks, Scott. Good afternoon. My name is Jeff Rivkin. I am the research director for payer practice for IDC. IDC is a research and market intelligence firm. We've got about 1,100 analysts all over the world, focusing on all kinds of verticals and energy, manufacturing, so on. And they pay me to research and write about and consult to the healthcare insurance industry. My background is very diverse, as you see, but mostly the thing that drove me to this job was I was an enterprise architect for Blue for about 10 years. And in that role as enterprise architect, I got to see the business, I got to see the technology as we implemented many, many things as we went through the tumult that was the insurance industry in the last 10 years and going on forward. So what I'm going to talk about today is the context of payers and health insurers, what is going on and why we have the situation we have. A lot of it's in the newspaper, which is sort of cool for me. A lot of it's not. And hopefully you'll get a little more today out of under the covers, sort of the inside baseball that you might not see at the highest level or when the top politicians talk about it. And then we'll talk about it after that context is given to you. We'll talk about digital transformation, which is all over this conference, and people are doing a very nice job of it. IDC's got their own ladder of maturity. We'll talk about that a little bit. And we'll talk about why Appian sort of fits into the idea of digital transformation a little bit. Not an endorsement, but it's a little bit. And then we'll talk about the patient of one and how you as a consumer of healthcare services and a subscriber or member of a health plan should be treated like a patient of one, not a member or a subscriber or whatever they call you these days. I'll give you some guidance. I'll show you some reports we've done, and then we'll leave some questions for the end, okay? So the context for the digital transformation is that there's just been such disruption. And that word, I think if you were to talk about most of the industries that are represented here or any other conference, I think health insurance wins. There was the beginning of operational disruption started about 2011 when there was a thing called medical loss ratio. And somebody decided that you can only make so much money. If you made too much money, you had to give back premium. 80 to 85% of your expenses had to go of your premium, of your expenses had to be expenses, and the other so that you could keep. But if you weren't spending it on administrative costs, there was actually a law that said you had to give the money back. And that was the beginning of the compression of the industry. You can call it a lot of things. Some people call it socialism. Some people call it compression. 2011, 2012, there was a lot of denial. We're not going to have this ACA thing. Obama's not going to win another term. Supreme Court's going to bail us out. We're not going to have to do this stuff. We're not going to have to do what we think we're going to have to do, which is basically have a situation where open channels with ununderwritten people are going to be put into the health insurance pool, no idea what their risk is, and we're going to open it up, subsidize them, and figure out what we're going to set our premium rates at. Well, Obama won 2012, Supreme Court did what it did, and we were where we were. Seismic disruption, enrollments, contracts, billing, subsidies, and a thing called the 3 Rs, which is the back-end way for insurance companies to actually survive. Basically what happened was, in a fairly short summary, you had a situation where the the ununderwritten people came into your organization as members, but you didn't know what their risk was. So you didn't know how to set prices. And on the back end, the government and the ACA said, we'll make you whole. If you take on too many risky people, we'll make you whole. If you take on not enough risky people, we'll balance out the industry. If you make too much money because you've collected too many premiums and you haven't paid enough claims and you had a less risky population, you made too much money, you'll actually give the money back and you'll have a flat industry. Some people call it socialism. But in 2014, somebody paid attention to the back-end payment and called it insurance bailout, so it didn't happen. And they said, wait a minute, we took on all these risky people and we didn't know how to price the products because we had no risk pool to understand. So we priced them what we could, and we got denied by 3/4 of the states when we asked for 40% increases and got 10. People lost their mind over 10, but we wanted 40 to break even. We only got 10. Now you're not going to pay us on the back end? We're out. We're done. Okay. Fast forward, you're hearing how this whole thing's going to explode in a year? That's because these back-end systems were only supposed to be in place for 3 years. The reinsurance, risk adjustment, quarter payments were only supposed to be in place for 3 years. So when you're hearing Trump and everybody else talk about it's going to all blow up next year, it's all going to blow up next year. Premium is going to go through the roof because there are no payments at all, even in the law, even in the original law. So you'll start hearing about reinsurance, risk adjustment, risk corridors. You're starting to hear about risk pools. You're starting to hear about a lot of things in the next 6 months. That's what you hear in the news. What's going on under the covers, the inside baseball stuff, is panic. We don't have money. We're not charging enough premium. We're paying out for these risky people. We've got all these administrative burden on us to handle these exchanges that are coming in from every state exchange and federal exchange across the country. A little bit of disruption. Meanwhile, exchanges woke up the consumer. Hey, it's sort of cool to shop for insurance and be able to pick and choose. You know, how many of y'all have, let's do it this way, how many of y'all do not have employer-based health care? Most of you probably have an employer-based, that you have a private insurance policy.
I'm not from the US,
So this room, and I understand it because I do this all the time, this room doesn't really necessarily understand that 30% of the country buys their insurance privately. 30%. It was 10, now it's 30. Small groups said, I'm out. I can't afford it anymore. I'm out. Go buy something. Or maybe they gave their people $4,000 and said, go shop, defined contribution. But the customer said, hey, you know, this is cool. And you know what? If I don't like it, I can leave. And 30% of the people, 30 to 50, depending on who you're listening to and how you count, the first year they pick somebody, and the next year they pick somebody else. And the next year they pick somebody else. Because they usually shop on price. They don't realize what they're not getting, like everything else. But the consumer's awake now. And they're awake, and you hear about the Amazon experience and blah, 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 blah. But the bottom line, the consumer's awake. It's not just open a room and check the box. Okay, and I've been doing this forever. My wife at the time was a lobbyist for the insurance industry, and we couldn't figure out in October or December which plan to pick from. And we knew what we were talking about. It's hard. Sit down and figure out what plan you're supposed to get. Read the future, guess your deductible, guess your high deductible plan, what premium, guess the future, hope for the best, hope you don't get pregnant, blah. That's us. We knew what we were doing. I understand why people check the box and say, whatever I had last year was good, this year it's good. Or in the old days, my grandparents was, it's blue, it's good. You know, that's what it was. But consumers woke up and they said, you know what, I demand, I require, or I'll leave. I require a decent customer service experience. I require a decent enrollment experience. I require a decent sales experience. I require a decent clinical experience. So when I need help and I want to try to navigate the health system, you'll help me. I demand a decent mobile experience. I want to have a situation where I understand what's going on because you know what? I'm getting older. We're all getting older. The demographics are shifting. People are older, wiser, and they're counting pennies. Consumer engagement. The insurance industry, the health insurance industry was very arrogant for many years. Look at the terms we use. Renewal, membership, subscriber. I don't know how many of y'all work for payers? How many of y'all have an assumption that they're going to renew next year in your systems? For example, you have a subscription. It's from October, or let's say January 1 to December 31. When I got to a Blue that I used to work for, there was no end date on the subscription. It assumed you were going to continue. I subscribe to Sports Illustrated. I don't, to assume that all your workflows are based on assumption of renewal, that's pretty arrogant. That's not a customer focus. And so when people did leave or come back or change policy, it was an exception procedure instead of renewal. Wow. Our operations were based on a concept of they're going to stay with us. They can't go anywhere else. We're good. Consumers woke up. Oops. And now the one that's coming, the big one. Started last year, year before, give or take, depending on account, value-based reimbursement. Value-based reimbursement, basically, for those who don't know, it's basically a concept that says a transaction is no longer a transaction. Today you have a situation where you go to the doctor, have an encounter, get a prescription, whatever it is, it becomes a transaction. You do something and it gets paid for, one for one for one. It becomes a claim line item, the claim item gets paid, it goes into the general ledger. A transaction is a transaction. If you go up to your CFO and you mention that the transactions are no longer going to be transactions, he's going to ask you what you're talking about. And when he hears what you're saying, he's going to lose his mind. Because basically you got a situation where, depending on the model, and I could do 4 hours and a half, on the various models, we're basically moving from a fee-for-service, transaction, to a situation where an episode or a person is being paid for in a concept that is broader than a transaction. And the old example of the knee replacement is important because most people understand it, and it's complicated enough but not too complicated. The idea being that instead of paying for the X-ray and the CAT scan and the MRI and the PT and the cortisone shot and the procedure itself and the anesthetist and the facility and the PT on the back end and the brace, fee for service, transactions of transaction, you pay 35 grand for one thing. That's an example. There's a lot of different examples, but that's good enough for the discussion. Give 35 grand to that group of providers and they'll figure out who gets paid what, because they'll have systems to figure out how to pay what, because they'll be incented to work together, not do duplicate testing, have better quality because they'll be working together and communicating better. And so cost gets better, quality gets better, and life is better across the board. And the patient's happier because they understand the concept. On the other end, a transaction is no longer a transaction. I've now got 9 transactions, 3 of which may have already occurred. Oh, it's really a knee replacement. You know those 3 things you paid for? We got to back them out because really it's part of the $35,000 bundle. Whoops, what? 60 to 80% of transactions in health insurance are going to be fee for value in 2020. Now, all over this conference, I've been seeing how digital transformation is used to encourage you to make money and to explore new avenues and channels and come up with innovative ideas. How about it's going to fix you from breaking? These companies are breaking, if they're not already broken. Split billing almost broke most claim systems. The ACA, part of the ACA that did subsidization. You're all there. That's nothing. I wrote a report that said the level of effort you put in for exchanges, it's about the same for value-based reimbursement, but it's more traumatic because if you don't succeed, you're done. You can't count the change. You can't track the money. If you can't track the transaction, you're out of business. You need a decent system of record because now you've got this 35,000 pool of money that goes to 9 different providers. I love the word provider. What's a provider? Food truck's a provider. A yoga teacher. Acupuncture specialists. I don't know what a provider is, and I've been doing this for a long time. Because I want my providers to be my spa and my haircut and my grocery store coupons and my yoga teacher and my psychiatrist and various other people and my naturalist and everybody else. That's my network. That's what I want. But I digress. Product systems, contract system, network systems, all of them got to be rethought. Because now these 9 people are virtual. This $35,000 goes to a virtual 9 people. So I have to have affiliations between them. so I can have a contract with them, so I can agree on $35,000 or $32,000 or $28,000. That's what should it be? Little disruption. Organizationally and technically pervasive. That's the only way you can put it. Look at these organizational situations. Finance has lost their mind. They're retiring. They're quitting. They can't deal. You're telling me I got general ledgers and sub-ledgers and what? This mill magic back box that says $35,000 comes in and some things go out and cost of care is what? And, okay. Product definition, contract modeling, workflow. To coordinate the ability to have these contracts be negotiated and serviced, and claims to be paid, and appeals to be handled, and enrollment to be managed, in a situation where you've got value-based reimbursement. I'm not talking about value-based care. That's a different thing. Okay, this is value just reimbursing, figuring out the numbers. Provider contracts have been blown up. Episode recognition. What is a knee replacement? Is it those 9 things I said, or is it 12 or 13? Does it include the brace? Does it include how many PT visits does it include? What is this thing? Claims processing. Claims pricing was pretty easy. Yep, that's a CPT code. We're going to pay this much. You got to do that, sort of. You got to do it on the covers, but it's not what's really happening. That's just the organization. Think of the workflow that has to happen to keep these things together. Technically, all these systems that are up on the right side of the board were in your claim system in a lot of ways. Now they're not. They're all been parsed out into special systems. Product configuration, to be able to build products on the fly. Plan management, to be able to file products. File that $35,000 to the state, and this state, and this state, and this state, and this state. Get it approved and agreed. And it's not just a product gets a rate, and that rate gets negotiated down from 40% to 10%. Thank you very much. It's now procedure by procedure, episode by episode, episode type by episode type gets negotiated at the state level. That's a lot. Contracts, appeals, the 360 view of a person. Finance, obviously. Rating, pricing, care. Network management, the new affinities. Be able to connect these providers together. And the idea of provider relations. That we're doing the best we can here, guys. Here's your 35 grand, go have fun. Well, I didn't get my money. Well, that's not my problem. I send it to your billing entity, and you're supposed to handle the 35,000. But I perform a service. Well, it's education. It's a different game. And fundamental revenue transformation is coming, and it's being underestimated. This industry will break if it doesn't transform. If that wasn't bad enough, insurance companies used to be, and I remember, we'd collect premiums and try to deny claims. That was sort of the job. No, now we're your partner in care. Look at the billboards and the commercials, and we're with you together. We've always been with you. We're going to be with you. Because the consumers are expecting that I need help navigating this health system. So we used to talk about utilization management. Are they a high utilizer? They're submitting a lot of claims. They're sick. They're people. I digress. Pre-auths, referrals, patient-centered medical homes, accountable care organizations, provider-owned health plans. Provider-owned health plans. How many of y'all are in a provider-owned health plan? Okay. 53% of the health plans in this country are provider-owned. Not lives, not number of lives, but if you took a list of all the health plans in the country, 53% of them are owned by a provider group. This is a real thing. This is happening. Okay? And it's growing. Because people are tired of the cantankerous oppositional relationship between payers and providers. Providers are going into the payer business. Payers are going into the provider business. Mergers are happening. Joint ventures are happening. It's becoming better, I think, for the consumer in a lot of ways. And administratively, there's obviously savings to be had. But the traditional insurance companies are dipping their toes. Risk management. We talked about risk. What's insurance? Managing risk. things are tight, costs are tough. We're starting to say, hey, risk management's a revenue opportunity, not just a compliance situation, it's a revenue opportunity. There's Medicare dollars on the table, and there's risk management dollars on the table. If I can figure out gaps in care, and I can get those people to come in the office, and they can be put in my risk pool, I get more money from the government or from my sister organization who I balanced out with. So risk management's a big deal. Risk management analytics is through the roof. I can give you 20 companies off the top of my head. Stratifying your members, your providers, your employers, understanding your market. Huge. HEDIS, rules changed, quality care, quality is peak. This is traditional stuff. Risk adjustment, revenue management, fraud, waste, abuse, the claims editing, all those traditional stuff still changing. On top of that, people are trying the CRM concept of patient of one, and we'll talk about that at the end. They're basically saying, claims data, enrollment data is over here. I've got a lot of clinical data. I'm doing care coordination, I'm doing PCMH, I'm doing ACOs, I'm doing admissions, discharge, and transfers from hospitals. I know your labs, I know your prescriptions. I know a lot about you. Let's put that data together and figure it out and treat you like a person, a patient of one. IDC has a maturity scale for all of our industries that we study. And payers are about as low as you can get. Why? Well, not a lot of competition, not a lot of customer sensitivity, not a lot of change. Now, most of this is local. I mean, if you're in Florida or Boston or some areas of California, there's a lot of competition, a lot of neat stuff's happening. But the vast majority of the country has 1 or 2 or 3 or 4 dominant payers and 1 or 2 or 3 or 4 dominant health systems, if that. Not a lot of competition, not a lot of market share chasing, not a lot of innovation, a lot of fat, happy companies just sort of perking along. It's no accident that Florida and California and the Boston area are the innovation centers for a lot of this kind of stuff, because that's where market share matters. But for the vast majority of the country, you have digital resistors and explorers and players. You're down here on the scale. We're not talking about, optimized, wonderful, disruptive, leading edge, innovative companies. We're really not. And so it's ripe for digital transformation. So there's your environment. Internal chaos, external demands from customers, significant concepts of data melding to become a patient of one, and a maturity scale that says we haven't really paid attention to innovative and new thought for years, if ever. Digital transformation really has, in my mind, there's 5 pieces of it for IDC, but really 2 of them matter to me. One is the infrastructure transformation. Using cloud or hybrid clouds to establish an analytical environment where opportunities can be identified. We talk about risk management, talk about payment integrity, talk about care coordination, you talk about network adequacy, you talk about a lot of different analytical categories where this is making a difference in infrastructure. Where you move from what happened, BI, EDWs, things like that, to predictive analytics and competitive advantage. The second part out of the 5 that I think are relevant of the digital transformation pieces is the idea of operating model transformation. That's saying your operations are digitally connected. And if you look at the Appian suite, it does a nice job of being able to pick and pop, right? A lot of these applications you're seeing through these demonstrations and on the floor, I'm pulling disparate situations and I'm building, not bombing and rebuilding my legacy situation, but I am taking and connecting my assets digitally. So what do you see? You see product configurators, you see prospective and reimbursement and retrospective reimbursement engines. Remember prospective? That's going to be a knee replacement. I think it's going to be a knee replacement, predictively. And it was a knee replacement. Back out all those old claims retrospectively. Okay. Provider network and contract management engine and ubiquitous workflow. If you got nothing else out of what I'm talking about after lunch here, ubiquitous workflow. The ability to plug and play and move around your organization, ubiquitous workflow. Not point solution workflow. Ubiquitous enterprise-wide workflow. To allow connected systems to fuel revenue streams, control costs, and manage risk. Unfortunately, we're down here with operational, trying to tweak things. But that's what we got to get to. So health insurance companies need to work on operating model transformation and infrastructure transformation. Why don't we do this? First of all, the line of business, when Appian or any vendor goes in to sell to a health insurance organization, a payer, they go where? They go to the LOB. They don't go to IT. Okay? And that LOB has a problem, a point solution problem that they need to solve. And they call it an initiative. And they have a year of initiatives, and they have a wish list, and they cut the line off, and they say, that's what we're going to do this year. That's not an environment to set up ubiquitous workflow. Okay? It's not an innovative environment. It's a technology point solution, solve my problem, check the box, make it go away, please. That is not how you fix an organization who's going to be devastated because a transaction is no longer a transaction. Emerging technologies and project management. This is basic stuff, apple pie stuff. IT itself, and I call myself IT still, we don't have any people. Our systems are horrible. Nobody wants to do it. We don't work real well with our business. CEO and the CIO don't get it. And we don't get paid to try and fail. Okay, I get it. So what do? We're payers, what do we got to do? We got to move this to, we're scared to death. I've scared everybody the first 10 minutes, sorry. But what are we going to do? First of all, set up a legitimate analytic environment. Set up an environment to understand your administrative and clinical situation for your people. You've done a pretty good job with administrative. You've got a pretty good situation with clinical profiles because things are coming in and you built your little system to hold like an EHR in your systems. Now you're going to work on provider profiles, your financial situation. Get your analytic act together. And you can do that. You got the tools. You probably do. They're probably point solutions, but you got the tools. Then use the cloud as a service backbone, as a services backbone to lower your expenses, to find some money. That's how I find money. Okay? It's a lot of economies of scale and moving your data center to somebody else. And then focus on your customer and understand how to buy, sell, market, and service customers in an omni-channel experience. Listen to your customers, be what they want. And operationally put yourself together so you can do that. They're not members or subscribers. They're not utilizers. They're not claimants. They're not a peeler. A person's a person no matter how small. I think Dr. Seuss said that or something. We're people. You have a high illness burden value. What? You're sick. Everybody in this room's got an illness burden on their head. You all know that, right? Just like a credit score, we've got an illness. We know. We know what your illness burden is. So we understand you clinically. We understand you administratively, what your enrollment is, whether you get a subsidy, how your claims are situation, are you a peeler, are you a pain in the neck, and do you pay your premium on time? We understand that. We understand we marketed to you. Are you part of an employer pool? We know where you live. We know your zip code. We understand your segmentation. We understand what you might want as a benefit design. I know what I want my benefit design. Nobody's really asked me, but if you did, I could tell you. And that's what wellness was all about, right? If you make it attractive for me to stay well, I will. And if I can stay well, then I cost less. It's money. It's not like, you know. And for a provider network, what's a provider? Does my spa count? Does my nutritionist count? Does my pharmacist count? Does my minute clinic count? Does my food truck count? I wrote this about a year and a half ago. It somehow was perceived as profound. I have no idea how. but we don't do it. How many of y'all who are payers have a true member 360? I know what my people are. I know what they want. I know how to sell to them. I know how to market to them. I know how to service to them. I know what their provider preferences are. I know what their product preferences are. I know what their claim situation is. I know what their medical health record is. You have one? Was that a hand, or is that just you just flexing your hand fingers? And how many people even do a illness burden score? We did. When we were doing a PCMH program, we had to know who the almost sick people were. The sickest people were in disease management. The almost sick people made it to the PCMH program. How do I do that? Segmentation. Attribution segmentation. Been doing it in marketing for 100 years. I think we're close to time almost. Some questions. So to summarize, lots of disruption. A huge disruptor, perhaps fatal at times. Different perspective, money's on the table, pay attention to the people, and recognize that something like Appian can give you, because it attacks infrastructure and operations at the same time, a nice little tool to get you to digital transformation. Oops. Because it's platform as service, you have lots of flexible infrastructure. You have data-centric applications, which helps the operational model. You can focus on the things they focus on well, case management, claims, and I understand directories as well. And then real-time access to those legacy stovepipes that give you the agility operationally. That's why I wanted to come here, because I think you guys, it's a nice little tool to help you get from A to B. Questions? I think we have about 5 left, right? Give or take. Questions? 10 minutes. Questions? Anybody about this? Sure.
Provider-owned plan.
Yes, sir.
That's easy enough for me to understand. I understand the motivation. Payer-owned plans. Payers doing the care.
Payers becoming health systems?
Yeah.
Yes.
That's the one that
Sure.
strikes me as unusual.
Not really.
Do you see more of
There's a lot of organizations who think they know how to run an insurance company. There's in Maryland, there's a hospital system called MedStar, and they tried to get on the exchange to sell insurance.
No, I'm going the other way around.
So
Okay.
United's done a lot of that, right? I mean, they're purchasing physician practices.
Oh, the other way,
surgical-
payers. Yeah. Well, you can either. Yeah, there's lots of ways to get there. The big guys are setting up creative organizational charts to handle non-for-profit and for-profit and products and things. It's hard to run an insurance company. I think the co-ops had a lot of problems, but I think the co-ops proved it's hard to run an insurance company.
The risk order vanished. Goodbye.
Risk order killed co-ops. Mostly because the big guys could figure out numbers better than little guys. The younger people, the healthier people went to the co-ops, so they had a better risk pool. But big guys had enough money and analytics to throw at the fact that, we have some really, really sick people here, and the numbers showed themselves. But my opinion is that I think that the co-ops didn't have enough horses to prove the numbers that they needed to prove to survive. They probably had a decent situation, but they couldn't prove it.
They didn't have the volume. I mean, that's right. You need the numbers.
No, I think
too.
they think they had an administrative problem, and the average co-op was running an IT shop of 1/5 of the size of the average payer, because they clouded everything out and contracted everything out, and they didn't really understand that this is a survival technique. If I don't keep these people in my risk pool, I'm not going to have a business anymore. They didn't get it, and when they did get it, they didn't have the horses to make it happen. That's my opinion. That yes, but if it all would have worked out, they would have gotten their money, but they couldn't prove it. Great question. Anything else?
What's it going to take for an Oscar health type company to make it bigger, make it more national? Markets.
Make it bigger, or make it national? There's 3 questions there.
Like, how do they get to the next level of literally being
They had the right idea.
So you can just repeat the question.
Oh, I'm sorry. The question was, how does an Oscar or somebody else make it when they didn't this time. You got to pick your markets carefully. New York's tough. You have to have a friendly regulatory environment. It was a disruptor because it existed. The second time usually wins in these things. First one rarely wins, the second one usually does. So whoever, Oscar 2 would probably win. Lessons learned. I don't think there was anything wrong with the model. They went direct to the people and said, what do you want? And we'll give it to you. And then you look at some of the tools that are out there, like some of these product configurators that allow you to say, this is the product I want. Take my wellness, my spa, my various other things that I want, that I can't get there, but I can get here. That's a loyalty play, and I can do that. The co-ops and Oscars and Livongo and WonderCon, all those guys did us a great service. And probably, if somebody decides that going into the insurance business is a good business thing to do, which right now it isn't, because it's in just such turmoil, not a lot of new insurance companies are popping up these days in health insurance. I saw Deb's thing about auto and life. There's a lot of disruptors going over there, but a pure insurance company isn't happening these days. Thank you for the question. Anything else?
We have a couple
Yeah, go ahead,
things
sir.
about. So one I didn't run by you, but I'll hold that one. But it leads into based on what Joel's question, I think. So what is healthcare different than other industries? We've seen technological advances that drive down costs in other industries. We don't seem to be seeing that in the healthcare industry, and there are other forces in play that make healthcare different than other industries, and we continue to keep it privatized, whereas our European friend left, but most of the rest of the world continues to be single payer. So what's different about our healthcare system?
Wow. Okay.
In 3 minutes or less.
3 minutes or less.
Yeah.
I think there's 2 or 3 things. The number one thing is the concept of privacy. I do this for a living, and I got called by Merck about 2 years ago and said, how do you like our new medicine that you're taking? What? How do you know what medicine I'm taking? Now, it was for a condition that could have had a lot of things, some of which would be embarrassing. And I said, and my initial reaction was, how the hell do you know what I'm taking? And of course they know. I mean, the pharmacy, the value chain. And if I had that reaction, what is the average person's reaction to privacy in healthcare? I was at a seminar at Harvard, and there were some people from Canada there saying, you guys with privacy in this country have lost your minds. We've been doing this since 1947. It all works. You just don't trust the government can understand and provide you the economies of scale, the infrastructure to allow you to have a decent healthcare system, because you've got this concept of privacy that you're just not going to tell the government whether you're sick or not. Well, we know, by the way, and they know too. We all have an illness burden score, but people don't want to think about that. That's one. The second big thing is price transparency. Until I can go into a doctor's office, and I can walk into like McDonald's and say a Big Mac costs $1.39 or whatever they cost these days. I don't know. I'm not supposed to eat them anymore. Until you have that says, for you, Jeff, your Big Mac's going to cost you $1.39. Your procedure, because you don't know going in because you haven't been diagnosed. But once you're on your way out, you sure do. What did this cost me? This visit and the prescription you just wrote me and the 5 PTs you just told me I was supposed to get and the CAT scan. Until there's that concept of, I see what it's going to cost me. How many of you all have had a situation where you needed an MRI? Anybody? Did you say, is this going to cost a lot? No, you said, I want the MRI. Or the CAT scan, or the. Did you ask what the prescription cost? Did you ask, anything? You go into any other environment, a car dealership, or anybody else, you're going to say, what's it cost me? Is it worth it? It doesn't happen. It's not top of mind. We don't think that way. So there's no price transparency. We got this privacy situation. It's a vicious circle.
And we're not paying out of our pocket oftentimes, right? It's you don't have the consumerism, but we've tried consumer-driven healthcare, and that's more consultant-driven healthcare, and I think it hasn't, that's certainly not the answer right now, and I know
Well, all we succeeded in doing in consumer-driven healthcare was to raise the deductibles, which caused people to be paid attention to what they were paying for the first $1,000. And you know what happened? People didn't go to the doctor. I can't afford the $200 copay. I can't afford the $50. I can't afford the first $1,000 or first $2,000 or the $30 copay or both. I can't afford it. I'm not going. So we've got this wellness-based incentive program that says keep you well to keep you going, and then we give you a $2,000 deductible and tell you, and unless you have something big, you're not going. So you get nickel and dime, all of a sudden you end up with rotator cuff surgery or whatever it is going to cost you big because you didn't go to get a little PT when you could have fixed it.
But we called it the Affordable Care Act, though, right?
That's semantics are wonderful, aren't they? Anything else? Well, I thank you all.
Yeah, and I'll
Appreciate
just wrap up with this. So Jeff and I I pushed back a little bit on the transparency. We had a good discussion around that, and I'll end our session with share a quote from somebody I once heard. Said it's, what's different about healthcare, it's hard to be cost conscious when you're unconscious. So I think, there's a lot of truth to that. When you're lying in the hospital bed or you're wearing that little Johnny with everything hanging out there, it's a little compromising to be asking you, how much is that going to cost now? So anyway, I want to thank Jeff for his time.
If you're interested in memory research, you can find it through our subscription, our website. You can email me. We can talk about it. It's a subscription service. A lot of this is for pay. Reports, I write a report once a month, but some of it's public, and you'd be willing to have it. If you have some things, there's my email address. We'll go from there.
And Jeff will be around the rest of the afternoon and evening, so if people want to sit down and spend a little time, have a conversation, he's available.
I could be had for a beer.
Thanks, everybody.